So there's been a tremendous number of advances for follicular lymphoma, with some new data being presented this year at the ASCO annual meeting, and then also published within the last several months. One of the key pieces of information that we learned today were the initial results of the Relevance trial. So to put this trial in perspective, which was presented by Dr. Nathan Fowler, this was a clinical trial based on clinical synergy of lenalidomide along with rituximab. So several groups, including the MD Anderson Cancer Center, as well as the Alliance Cooperative Group within the United States, and several European groups have found that the addition of an anti-CD20, such as rituximab to lenalidomide, appears to be clinically synergistic with very high response rates and very high complete response rates for both relapsed as well as treatment-naive patients with follicular lymphoma. So based on that premise, the Relevance trial was designed as an international trial funded by the Pharmaceutical Corporation, but run through LISA, as well as several sites within the United States and other European countries. And the purpose of this trial was to compare lenalidomide and rituximab, also nicknamed R-squared, against chemoimmunotherapy for patients with follicular lymphoma that needed treatment. So this was a high tumor burden patient population. Over 1,000 patients were enrolled with over 500 per arm. And the treatment was the investigator's choice for chemoimmunotherapy, which could have been R-CHOP, R-CVP, or bendamustine and rituximab, versus the experimental arm, which is lenalidomide and rituximab, first given for 6 months, and then with a dose reduction allowed in the lenalidomide for an additional 1 year of therapy, as well as maintenance rituximab. And the patients getting the chemoimmunotherapy also had maintenance rituximab. What we learned today is that the overall response rates and the complete response rates were actually quite similar between the two groups, and that there is no difference in progression-free survival. In fact, the curves were overlapping, and overall survival was excellent at 94% in both groups. And so, some people have come away from this saying that perhaps it's a negative study. It did not show superiority of the experimental arm over the chemoimmunotherapy. But I think this is somewhat controversial because chemoimmunotherapy has its own risks that have to do with cytopenias, neutropenic infections, the need for antiemetics. In the case of R-CHOP, there's clearly anthracycline and vinca alkaloid type of toxicity. And those are some of the real, as well as the need for growth factors, which was threefold higher in the chemoimmunotherapy group. Others would say that not only did the lenalidomide and rituximab not reach its primary endpoint, but the cost differential is quite substantial. And lenalidomide for 18 months is quite expensive, and if there is no difference in progression-free or overall survival, how do you justify that type of a costly treatment? So I think we will be parsing this information for months to come, maybe years to come, and of course we need long-term data to know whether or not there are some differences that emerge with time. The other new piece of information over the last several months has been the advent of all of the PI3 kinase inhibitors in follicular lymphoma. So idelalisib has been approved in the United States for several years now for indolent lymphomas that are refractory to alkylating agents as well as rituximab or anti-CD20s. And now we have another agent that just was recently approved called copanlisib. There are some differences between idelalisib and copanlisib in that idelalisib is a pure delta inhibitor of the PI3K isoform, whereas copanlisib has both PI3 kinase delta and alpha inhibition. And this changes the side effect profile somewhat in that by inhibiting alpha, we see more hyperglycemia, we see more hypertension, but so far this has been transient, and the response rates seem to be quite comparable to idelalisib, with about a 60% response rate and some CRs as well, probably on the order of about 15%. So deciding between these two approved agents in the United States, I think, is also somewhat controversial. Idelalisib is orally available. Copanlisib is available as an intravenous formulation that requires weekly administration for 3 weeks out of 4. So I think deciding between the two will likely be related to cost of care and patient preference between an oral versus an intravenous delivery. And I can just end by saying that there are some other PI3 kinase inhibitors that are in very mature development, including duvelisib, umbralisib, and these agents will hopefully also be available to our patients within the near future.